This seminar is going to discuss end-of-life issues and ethical dilemmas in the ICU. I am Kathleen Haley, and I am one of the pulmonary and critical care physicians at the Brigham and Women's Hospital. I have no conflicts of interest to report. A brief outline of what we'll be discussing. First, why should we be concerned about end-of-life issues in the ICU? Some basic concepts about ethics, family impact of ICU care, how do considerations of religion and culture impact ethical and end-of-life issues in the ICU? We'll review some advanced directives, especially as they apply to ICU patients, and then we'll move on to decisional capacity and informed consent in the ICU. We'll also discuss the issue of potentially inappropriate care requests and review a couple of other common ethical dilemmas that occur in our ICU patients. So first, why should we be worried about end-of-life issues in the intensive care unit? Well, ICU and critical illness carries with it a significant burden of not only morbidity, but also mortality. A 1999 state-specific survey of mortality statistics found that 38% of all deaths occurred in a hospital, with 22% of these deaths occurring in an ICU. A subsequent follow-up study showed that even though there has been great education about palliative care and the availability of hospice care, 22% of Medicare patients with cancer died in the acute hospital, and 40% of patients had an ICU stay in the last 180 days of their life. And this was from an updated study in 2010. Deaths in the ICU can occur as either a cardiac arrest and the usual code blue, as it's called. However, more frequently, it occurs when life-supported technology is removed. Therefore, we deal with end-of-life issues and ethical questions frequently in our ICU patients. As an example of the frequency of ethical consults and issues that arise in the ICU, the distribution of ICU consults from the Brigham and Women's Hospital Ethics Consult Service, and I want to thank Dr. Martha Yurchak for these next two slides. Since 2014, between 30 and 50% of our ethics consultations at the Brigham and Women's Hospital have arisen from one of our ICUs. The most common reason for an ethical consultation was a conflict over the goals of care. And as you can see, that was approximately 40% of the consults that were given to the Ethics Consult Service. The remaining consults were divided between a proxy decision-making conflict, general questions that included decisional capacity, provider and team communication, questions specifically regarding withdrawing and withholding treatment, and general communication questions. Again and again in ethic issues, the common thread is the difficulty of communication. As an example of this, in honor of Robert McCluskey and our Boston-based author here with getting our ducks in a row, I know that you believe you understand what I said, but I'm not sure you realize that what you heard is not what I meant. Communication is difficult, and when people are stressed, when people are tired, as they are in the ICU, when the issues are very life-impacting, communication becomes extraordinarily difficult. So, first let's start with some basic frameworks as we frame our ethical conversation. Generally speaking, normative ethics is the most commonly used framework for analyzing an ethical situation. or question. This involves 4 general principles: autonomy, respect for persons. This is generally considered the primary ethical consideration. Beneficence, doing well, doing good. Non-maleficence, which is avoiding doing bad. And also fairness or social justice. And the relative weight given to each of these principles is how we decide what is the best approach for this ethical conundrum at this time. Generally speaking, the option that will enhance patient autonomy is probably the best approach. But the other considerations must also be weighed in. Other frameworks for analyzing ethical issues include a duty-based or deontological framework, and this is that the consequences of the action will inform whether or not the action is right, but are separate from totally determining the rightness or wrongness of the action. And this gets back to the Immanuel Kant categorical imperative analysis. There is also a teleological or ends-based framework, and this is that the consequences or the ends are critical components in determining the right course of action. And frequent frameworks are a utilitarian, which is to maximize the greatest good for the greatest number of patients, and this would again have a very large emphasis on social justice or fairness, and sometimes to the counterbalance of autonomy. Or a virtue organization or framework, which is the right course of action is what a perfectly virtuous person would do. However, this can be very, very difficult to move from a theoretic, perfectly virtuous situation to the real-life practical situation. Nevertheless, it can be a useful construct to try to analyze an ethical conundrum. Again, the normative ethics, balancing autonomy, beneficence, non-maleficence, and social justice is the most commonly used. In the ethical issues that arise in the ICU, relationships are at the center. The core relationships in the ICU are the ones that we are most frequently involved with and recognize: the medical team and the patient, the classic doctor-patient relationship. However, in the ICU, the medical team is much more than just the physician and includes the entire multidisciplinary team. For our ICU patients, however, the relationships are more complex and includes the family, both the patient and family relationship and the patient and medical team relationship. So once again, the communication between the members of these relationship entities can get extremely complicated and are frequently at the core of the ethical questions that arise in the ICU. Critical illness impacts the entire family unit. Post-traumatic stress disorder has been seen in up to 69% of families with patients who die in the ICU. And depression is extremely common in families with family members die during their ICU stay. The way we manage the communication in the ICU can ameliorate the impact on the family. We need to be very cognizant of the way that we give bad news and also of the way we manage and schedule family meetings, scheduling being the frequency. Are they only when we have bad news to report, or do we have a regular communication to develop a relationship with the family? Following up with the families can be very, very important, and the social workers attached to the ICU can have a critical role in helping the families deal with the post-ICU trauma that they will be experiencing. Grief management is an important part of helping both patients and families with the losses due to critical illness. Dr. Kubler-Ross, in her classic work, identified a very stereotypical way of dealing with bereavement and grief, and that there are stages, but it's not really stages in a linear part. It's more that these are very typical ways of receiving and processing disastrous news. These include denial and shock, anger, bargaining, grief and depression, and acceptance. Because it is non-linear, it may require time, and the ICU staff may feel confused because patients and the families may move or bounce between the various stages of grief management. And so it is something that can have an impact not only on patients and families, but also on the ICU staff. And so ICUs that are most effective in dealing with ethical issues have supports both for patients, families, and for the medical teams. So the role of religion in how ethical considerations are approached in the ICU can be very, very important. Interestingly enough, the major religions have very similar teachings about what should be done at the end of life. There is actually no requirement for useless suffering among the major religions. However, patients and families will sometimes cite this as a reason for pursuing burdensome care, particularly since this is either due to not understanding the actual teachings of the religion, or since it will perhaps be a way of helping the patient and the family to process an otherwise absolutely intolerable situation, to put the onus onto the religious beliefs rather than what their own wishes would be. But it can be useful to talk with your chaplaincy service to understand what the precise teachings of a patient or family's religious traditions are, and you can help navigate that. There is usually a requirement among the major religions that people are required to seek and or accept help regarding their health. And there are some religions that will have very, very specific directions about either starting or stopping life-sustaining therapy. And the ICU team should seek assistance from the religious authorities in their local area regarding what specific directives might be at play for a specific family or therapy. Therefore, pastoral support can be invaluable both to families and the ICU team. The pastoral supportive team that has a prior relationship with the patient or the family is obviously the best option, and it can be extremely helpful, particularly if there appears to be confusion or conflict, if the medical team will talk directly with the family's religious advisor, because this can clarify things very, very frequently. Similar to religion, culture can have a huge impact on how patients and families approach things in the ICU. One wants to be aware, but also careful about the role of culture in our patients and their families. We don't want to stereotype. However, patients and families come with a context, and that context is culture. Interestingly, patients in hospitals across the United States have surprisingly similar views, despite our very heterogeneous ethnic backgrounds. International offices can be a very good resource for dealing with cross-cultural issues that may arise in international patients. It can be very important to have a medical translator also to not only help navigate some of the communication, but also as a resource for some of the specific cultural issues that may arise, particularly with international patients. The recommended approach is to be flexible with the families to both accommodate their specific beliefs about the end-of-life approaches, their preferred decision style, and just realize that that specific preferred decision-making style may be informed by their culture. Currently, in the United States, we use a shared decision model most commonly. However, We don't have to require that for all patients, and that doesn't work for all patients and their families. And so individualizing our approach can be a good strategy. Based on the primacy of autonomy, in 1990, the importance of the patient identifying their own wishes regarding end-of-life care was codified into law as a federal statute, the Patient Self-Determination Act of 1990. Advance directive allows for a patient to direct how their care should be at the end of life when they cannot themselves make a decision. Advance directives can also allow the appointment of a surrogate decision maker, frequently through a healthcare proxy, which appoints a healthcare agent to make decisions on the patient behalf. All states do have legislation regarding advance directives. However, there is some variation state to state. The healthcare agent, sometimes also called a durable power of attorney for healthcare issues, is the person who is designated by the healthcare proxy document to make decisions for the patient. The healthcare agent does not have to be a relation, can be anyone that the patient directs to make decisions for them. Ideally, it should be someone who is familiar with the patient and familiar with their goals and values. But for someone who does not have close relations, can be fairly much anyone who agrees to be their healthcare agent. Copies of the healthcare proxy should be widely available, should be with the patient's chart, the healthcare agent, the patient, and ideally also the primary healthcare provider. It is important to consider that the healthcare agent makes healthcare decisions during life, much as the patient themselves would. However, this may change after the patient dies. In some states, autopsy permission is under the purview of the healthcare agent. However, in other states, that is the role of the next of kin. The healthcare agent has the same prerogatives regarding any healthcare information as does the patient. And the healthcare agent's role is to use substituted judgment, which is to make a decision based on their best understanding of what the patient would choose for themselves. The best guide for this is the patient's clearly stated wishes, frequently in a written advance directive. The best interest of the patient, however, can be used if the patient did not clearly identify their wishes regarding a particular situation. If there are no designated healthcare surrogates, then the decision maker is decided by state law. State law varies. It's most frequently the next of kin. 7 states do not have any specific legislation about this. Kansas actually has a regulation only about research consent. These 7 states that lack regulations about surrogate decision makers that in patients do not have a designated healthcare agent are Massachusetts, Minnesota, Missouri, Nebraska, New Hampshire, Rhode Island, and Vermont. In the worst case scenario, if there's no next of kin and a decision must be made, synthetic judgment, which is a multidisciplinary team weighing the interests of the patient and what is known about the wishes of the patient to arrive at a synthetic judgment can be used, but it is not the favored approach. Some states do require a very clear statement from the patient requiring a very definite outline of what they would and would not want regarding their wishes in end-of-life situations, or may have specific limits on healthcare agent authority. And therefore, it is advisable to become familiar with the laws in your specific state regarding the roles and the limitation for healthcare agents. Some more on advance directives. So as we said, it was codified by federal law in 1990. The American Bar Association website does have updated information by states because this is something that changes every few years. Living wills are a type of advance directive. They do outline preferences regarding treatment, however, they are not legally binding in all states. Other, perhaps less formal statements regarding patients' wishes for care include 5 Wishes, which is a non-profit organization, Aging with Dignity's way of walking through frequently encountered problems at the end of life and having a patient write out how they would like those problems approached. And these will meet the state requirements for advance directives in 42 states and can be appended to the state required form in the remaining 8 states. There are other examples of written advance directives, including the Gunderson Lutheran Medical Foundation, which is based in Wisconsin, the Respecting Choices. Again, most of these written advance directive forms will have a staged approach to integrate planning for end-of-life issues into regular outpatient visits and to imagine scenarios that may arise, such as difficulty eating, mechanical ventilation, wishes regarding resuscitation, and so forth. Since the family is an integral part of the patient unit in the ICU, keeping families updated regarding the patient's course and likely prognosis and therapeutic options is critical. So we should talk a little bit about family meetings in the ICU. Planning them can be very important to the success of the meeting. A private area, a preparatory medical team meeting to decide on the important issues to discuss can be a very good way to ensure a well-functioning meeting. Developing a consensus approach to the patient's problem can really smooth communications, and the use of clinical milestones to do this can be very useful. Certain mnemonics have been developed, including one by Dr. Curtis and his group, which is VALUE. It's easy to remember. So V is value family statements, A is acknowledge family emotions, L is listen to the family. That's actually not usually done in our family meetings. Frequently, the medical team will talk more than 50% of the time, and so we have to be aware of the importance of listening to the family concerns. U is understand the patient as a person, which is critical to understanding their values and their goals for therapy. And E, elicit family questions, particularly at the end, so that we know what issues remain unclarified and what issues also are important to the patients and their families. Whenever there's communication, there can always be problems with communications, and so we have to have approaches to managing discord in the way we approach ICU ethics and end-of-life issues. Having a consensus plan among providers is critical to this. The providers may not have their favorite plan, but there has to be a plan that everyone can agree to, or else we will have a very chaotic approach to the family, and then subsequent discord would definitely not be surprising. Proactive and frequent family meetings can also be very, very helpful because that way the communication is given in small bits, and that is much easier for a patient family to process. Since the patients will also be changing, the small frequent family meetings can be a very effective approach to managing a dynamic clinical situation. When significant discord occurs, getting an outside opinion or advisor can very much be a useful strategy to help manage the discord and reestablish a consensus. Healthcare providers with a long-term relationship with the patient or the family can be a very useful adjunct. Frequently, the primary care physician is left out of the ICU, but reaching out to that provider can be a key element in the success of a family-patient relationship in the ICU, managing end-of-life issues. The ethics service in the hospital can also be a very good adjunct. The social services support can provide critical support for the patient's family. Most hospitals will have a family relations office, and they can also be a very good resource. And of course, pastoral care chaplaincy can be invaluable. Most hospitals will have a policy to manage intractable discord, which fortunately is very rare. Please be aware that following a policy will not prevent a lawsuit, but it will support that the healthcare team has managed the discord and the approach to treatment options in a reasonable and standard of care fashion. The importance of communication cannot be overstressed in dealing with ethical and end-of-life issues in the ICU. Things that appear to be a discord frequently are just simply problems with communication, and that is why bringing in an outside advisor who can bring everybody to the same table and in an objective fashion go over the issue so that everyone is clear as to the issues and the communications and the options frequently can resolve what appeared to be a serious discord. When there is discord, it can be a useful approach to identify areas of agreement first and then move on to more problematic area. Since both the team and the family have the goal of providing the best care for the patient, there is usually some level of agreement that can provide a start to move toward a common goal and communication, and this can be a helpful strategy. Reframing problems as shared opportunities to work toward goals that are important to the patient and the family and the team together can be a very helpful approach. Hang in there and keep communicating, and usually consensus can be developed. Sometimes, however, the patient or the family requests care that the team feels is potentially inappropriate. This is the older term, this is the term used for the older term of futile care. The reason why futile care is no longer used is referenced here by the great medical theorist Yogi Berra. In theory and practice are the same. In practice, they're different. So, futile care is problematic because it's generally in the eye of the beholder, especially as technology moves. What is potentially inappropriate care? It is medical care without a chance of success. It's an easy concept, but as we stated, it's very hard to define. There is physiologic futility, however, that's very rarely encountered. It would be that the treatment is unable to perform its intended function. It's encountered very, very rarely, and in some instances it can be a heart procedure on someone who has a defect in the anterior myocardial wall. It just simply cannot be physiologically done. Very unusual. Medical futility, which is much more open to a subjective assessment, is a treatment that is unable to reach a patient's goals. Since goals change, medical technology changes, this is extremely difficult to define. Most hospitals will have a futility policy. Texas is unique in that it has a state statute regarding the management of futility. We should say a word about comfort care when we're talking about end-of-life issues in the ICU. Sometimes the only goal of care is to alleviate symptoms, and that's usually referred to as comfort measures, comfort care. Usually, comfort care will involve the removal of life-supporting technologies, such as dialysis, ventricular assist devices, mechanical ventilators, or other life-supporting therapies, even sometimes a pacemaker. Ethically, removing a therapy is the same as not starting it in the first place. However, providers should be very much aware that not only for the medical team, but particularly for the patients and the families, removing supporting technologies will emotionally have an extremely different meaning than not starting in the first place. And the team should be prepared to manage these very difficult and conflicting emotions, even when it is decided that comfort care is the best option for the patient. There is concern frequently from the medical team regarding whether or not changing to comfort care and removing a life-supporting therapy is something that is ethically acceptable. And the justification for the ethical acceptability of removing a therapy is something called double effect. And this means that we accept side effects of what we do in the ICU if the benefit from the intent of the therapy outweighs the burden. For example, we will accept sedating side effects of opioids and benzodiazepines if our intent is to relieve pain, anxiety, and dyspnea. Interestingly enough, the appropriate use of sedating medications after removal of life-supporting therapy actually has been shown in at least one study to not change and perhaps extend the duration of survival after life-supporting technology was removed. Issues of end-of-life care, comfort care, and the law usually come up as at least questions. And there is now well-established case law regarding this. The courts have regularly upheld a patient's absolute right to refuse any type of care as long as they have decisional capacity. There are several landmark cases about this. They have also upheld that it is a different use of medications for symptom and pain relief, which is quite accepted, and euthanasia, again, using double effect as the justification. At this point in time, there is no right to euthanasia, although some states have been exploring doctor-assisted euthanasia, particularly Oregon. But note that anyone who is defined as an interested party can initiate a legal review of any practices in any unit. Again, good documentation, adherence to your hospital policies can provide justification that you have acted according to the patient's best interests, according to their goals and values, and have acted also within the standard of medical care. So the issue of how the legal aspects may play out is a frequent source of anxiety, but generally the courts have been very supportive of well-documented, careful decision-making by healthcare professionals, even in the situation where there is an element of discord between the healthcare professionals and the patient or family. Take-home points about end-of-life issues. They're very common in the ICU. The principles of autonomy, beneficence, non-maleficence, and justice provide a framework to analyze the ethical issues that arise in our patients. Sensitive communication can lessen the distress of the patient's family and the patient dealing with bereavement, because bereavement and grief is not just dealing with death, but also with the loss of the prior functioning that the patient will inevitably experience after an ICU stay. ICU physicians have a duty to provide good symptom control using palliative care to our patients who are dying. We're going to move on to other ethical issues that can frequently arise in the ICU. We're going to start with decisional capacity. This is distinct from competency, which is a specific legal term. Decisional capacity is the function of the patient in the ICU regarding their ability to make decisions. It requires knowing the available choices, appreciating the ramification of the available choices. And it's very important to realize as care providers that a patient with decisional capacity has the absolute right to make what we would consider a wrong decision as long as they know their choices and know the ramification of their choice and can indicate their choice. If there is question about decisional capacity, sometimes a psychiatric evaluation can be useful because decisional capacity can be difficult to assess in the critically ill patient. There are bedside tools available to make sure that the patient's thinking is not clouded by delirium. An example is the CAM ICU scale provided or outlined by Dr. Eli in this critical care medicine article. Decisional capacity is also not an absolute state. It is a sliding scale. It is decision specific, and the amount of capacity, the complexity of the decision, both weigh in as to whether or not a specific patient has decisional capacity for this specific question at this time. So it's important to notice that even patients who have cognitive limitations may well have decisional capacity for some decisions. In an academic institution in particular, research and conflict of interest sometimes arises in our ICU patients. Conflict of interest arises when a physician has dual roles. For example, if you as the attending ICU physician also have an actively enrolling clinical trial for which your patient may be eligible. That would obviously have a dual interest, and that would be a conflict. It's usually managed by making sure that the treating physician does not recruit patients into their own clinical trial. The ethical issues raised by conflict of interest is, of course, balancing the risk and benefits, because the investigator may not be able to clearly identify the risk and benefits of their study as it applies for their own patient. And informed consent in that situation can be practically impossible. Of note, also with conflict of interest, in some situations, healthcare agents are limited by state law in regards to consenting for research studies. And so again, being aware of the particular laws in your area is extremely important. We're going to move on to some questions. The concept of substituted judgment is best described by A, the medical team substituting for the patient by deciding what is in the patient's best interest. B, the designated surrogate decision maker using their best understanding of how the patient would decide for themselves as the basis for decisions. C, the medical team substituting for the patient lacking a surrogate decision maker by using the reasonable man standard. D, the care instructions outlined in the, quote, 5 wishes, end quote, or a living will. Or E, the court-appointed guardian using their understanding of the patient's best interest as a basis for decisions. So the best answer here is B, the concept of substituted judgment is best described by the designated surrogate decision maker using their best understanding of how the patient would decide for themselves as the basis for decisions. This is the definition of substituted judgment. Question 2. A 70-year-old man has just been admitted to your intensive care unit with multi-system failure, which includes shock, respiratory failure, and renal failure in the setting of pneumonia. His family consists of a wife, 2 daughters, and 3 sons. A close family friend is the patient's healthcare agent. The patient's healthcare agent visited the patient today and told the patient's nurse that the patient's youngest son was not to be allowed to visit nor to receive any information about the patient. The patient's wife and daughters, who were in earlier this morning, have left the hospital. They are expected later in the day. Which of the following is a correct statement? A, the son may not visit nor receive information since the healthcare agent has refused permission for this. B, no decision about the son's ability to visit or receive information is possible at present, since the patient's wife, as the next of kin, is the person who decides regarding whether her youngest son can visit and or receive information about his father. C, the son may not visit since the patient healthcare agent has refused permission for this, but he can receive regular updates regarding the patient over the phone. D, the patient's son has a legal right both to visit and to be informed about his father's progress. The healthcare agent cannot infringe upon this. Or E, the son may visit but may not receive information about the patient since the healthcare agent has refused permission for this. The correct answer here is E. The son may visit, but may not receive information about the patient since the healthcare agent has refused permission for this. Recall that the healthcare agent has the same prerogatives regarding healthcare information as does the patient. However, any family member, as long as they are not disruptive to the ICU setting, has an equal right to access to the patient. Question 3. Your patient is a 60-year-old woman with severe congestive heart failure and an ejection fraction of 10%, COPD with an FEV1 of 1.1 liters, and pneumonia. She has been on mechanical ventilation for 7 days. She does not have a healthcare proxy, but does have a living will indicating that she would not like support in the event of either a terminal disease or evidence of irreversible brain damage. Her family says that she has, quote, always been a fighter, end quote, and states that they believe she would want to continue therapy. However, the nurse caring for Mrs. Williams is uncomfortable with this plan. He points out that Mrs. Williams grimaces with mouth care and reaches for the endotracheal tube whenever her hands are not restrained. Which of the following would be the best course of action at this time? A, call an ethics consult, since the patient's current status is clearly unacceptable to her, but her family is requesting continued mechanical ventilation. B, arrange a family meeting to clarify the patient's values and goals and establish whether the current strategy is indeed congruent with the patient's wishes. C, adjust the patient's sedation so that she is more comfortable on the ventilator. D, all of these choices are acceptable. Or E, only choice B and C are acceptable. The best answer here is choice B and C. Whenever there's a choice that will have more communication to identify goals and therapy, that is probably the best option. There's a lot of confusion here as to whether or not the patient is truly indicating her discomfort with the vent or indicating that she does not wish to proceed with this therapy. Getting clarification about what is important to her and getting her more comfortable on the ventilator, however, not necessarily completely somnolent, will be important in trying to identify what is the best course of action moving forward. Question 4. Your patient is an 82-year-old woman who is on chronic mechanical ventilation and dialysis following an episode of sepsis. On morning rounds, it is reported that during the night shift, the patient was very, very tearful and wrote to her nurse things like home, words like phrases like not worth. This morning, the patient is calm but appears to have a flattened affect. She interacts normally with her medical team and participated as she is asked to do so in all of her therapy over the course of the day. The same report regarding unusual writing at night that are stressing not worth, home, but yet appearing to be normal and her usual self during the day, again recurs. What is the best course of action? A, start an antidepressant since the patient is having an appropriate reactive depression. B, ask the covering moonlighting resident to check on the patient. C, arrange a time to meet with the patient and her family to discuss her statements and what they might mean. D, ask the patient to clarify what she meant by her statements. E, start a low-dose atypical antipsychotic such as haloperidol in the evening since she is having episodes of overnight agitation which are symptomatic of delirium. The best option here is ask the patient directly to clarify what she means by her statements. During rounds, she's interactive, she's appropriate, she should have the first choice of clarifying what she means. If there is concern that she is confused or not being clear in her responses or is unable to communicate, then going to her healthcare agent and family to clarify what she might mean by these writings overnight would be the next step. But going to the patient first to ask her, does she remember what she is writing and what does she mean by what she is writing? That would be the first step. Patient 5. Your patient is a 54-year-old man who has respiratory failure due to acute myelogenous leukemia and pulmonary hemorrhage. His respiratory status is tenuous, and he is deeply sedated on the ventilator. His family asks you to start a new medication developed by his oncologist at your hospital that minimizes pulmonary hemorrhage in an animal model, but has not yet been tested in humans. They read about this medication in the local newspaper. What is true regarding using this medication? A, using this medication requires an IRB-approved clinical trials protocol for its use. B, the medication cannot be used since the principal investigator of the protocol is the patient's own oncologist. C, since the patient's clinical status is tenuous, IRB approval is not needed. The medication could be used under what is called compassionate release. D, the medication can be used if the family agrees to self-pay for it. Or E, the medication cannot be used since the patient cannot give his own consent. The correct answer here is that the medication would require an IRB-approved clinical trials protocol for its use. It is not standard of care. It is only used in animal models, and any such medication that would be moving to a clinical trial would absolutely require prior approval by the IRB and an outline of its use through an approved protocol.